Hello and welcome to our NYU Langone Orthopedic webinar. NYU Langone Orthopedic webinar, Shoulder and Elbow Surgery, Advances in Shoulder Arthroplasty, Updates on Indications, Design, and Surgical Techniques. Thank you for joining us. My name is Tyler and I will be the facilitator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. On the right-hand side of your screen, you will see the Q&A window. To send a question, click in the text box and type your text. When finished, click the send button or press enter. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed throughout and at the end of the presentations. We are joined today by our presenters, Young W. Kwon, MD, PhD, Eric J. Strauss, MD, Mandeep S. Virk, MD, Joseph D. Zuckerman, MD. At this time, I would like to turn the microphone over to Dr. Virk to get started.
Good evening, everybody. Welcome to the NYU Shoulder webinar series. I really want to thank everybody for taking time out to be a part of this webinar. The title for our webinar is Advances in Shoulder Arthroplasty, Updates on Indications, Design, and Surgical Techniques. And we have 4 speakers with us today. Dr. Eric Strauss, who is going to present non-prosthetic options in shoulder arthritis, will be followed by myself, humeral stem options in shoulder arthroplasty. The third talk is going to be by Dr. Kwon, who's going to be presenting expanding indications for reverse shoulder arthroplasty, and the last talk by Dr. Zuckerman, who's going to talk about guidance technology for shoulder arthroplasty, indications, and early experience. We encourage everybody to send us questions as we go along. We'll try to address these questions after the talks as well as during the group discussion at the end of the webinar. So I'm going to ask Dr. Strauss to go ahead with his presentation. And again, welcome everybody.
Hello, everybody. My name is Eric Strauss. I'm one of the sports medicine surgeons here at NYU Langone Orthopedic Hospital with a specific interest in cartilage repair and restoration. I want to thank you all for tuning in and thank Dr. Virk for including me in this panel and webinar. So we're going to talk about non-prosthetic options for chondral lesions and glenohumeral arthritis in the young active patient. So I do have some disclosures. I serve as a consultant on a few cartilage repair and restoration companies. So glenohumeral osteoarthritis in the young active patient, as we all know, is a very difficult condition to manage. It's truly a black box for us. And the reason is these patients tend to be young, they have high functional demands, and there are inherent limitations that are present following arthroplasty. We know that there's kind of a list of etiologies that can lead to glenohumeral arthritis. It can be post-surgical and post-traumatic. It could be primary OA, or basically local degenerative changes. It could be the sequelae of osteonecrosis of the humeral head. And it could also be a relatively uncommon but present location for OCD lesions. So we're going to spend a little time and just talk about post-surgical OA. So we know historically following non-anatomic procedures for shoulder instability like the putty plat and Magnuson stack that post-treatment or post-surgical osteoarthritis can be present. We've also seen chondrolysis following thermal insults from thermal capsulorrhaphy like you see in this case right here. Compared to the index procedure where the articular surface of the humeral head and glenoid are pristine, only 6 months after a thermal capsulorrhaphy, you could see global and progressive wear of the chondral surface of both the humeral head and glenoid, leading to significant joint space narrowing in that axillary X-ray that you see on the upper right. There was a current concepts review published in JBJS that defined chondrolysis as a syndrome of global rapid cartilage loss within 12 to 18 months typically following surgical intervention. And the authors found 128 reports that included just under 900 cases in the literature. And as you see in the table on the right, the shoulder was the second most commonly affected joint following the hip. If you take a look at the graph on the left, compared to mechanical contributors like prominent hardware and prominent suture stacks, the other two contributors to chondrolysis in the shoulder were thermal, as you saw following thermal capsulorrhaphy, similar to the case that we just presented. But importantly, the largest number of cases were for chemical contributors. And this developed following a phase where intra-articular pain pumps were being utilized for post-surgical or post-arthroscopic analgesia. So basically, surgeons would implant this intra-articular pain pump with 0.25% Marcaine, and there are a number of cases and reports like this one that was published in AJSM that showed rapid and significant chondral loss throughout the joint due to the insult from the local anesthetic. Not only does this lead to significant and very poor results in the patients that were treated with this attempt at analgesic postoperative approach, there was also a number of large-scale litigation cases. So we know that glenohumeral arthritis in the young active patient is present and can be relatively common. And when they come to our office, they typically come with a chief complaint of activity-related pain. And over time, and as things progress, it can develop into and progress to rest pain. Almost universally, patients report symptoms at night with symptoms that can even wake them from a sound sleep. In some of our more active patients, the primary complaint will actually be limitation of their range of motion, especially rotational range of motion, and it can go hand in hand with mechanical symptoms such as catching or grinding, depending on the extent of their cartilage loss and the size of the inferior humeral head osteophyte that may be present. Many times in these young active patients, their primary complaint will be limited ability to exercise that over time will lead to trouble with their activities of daily living. So the first question is, why don't we just jump to a total shoulder arthroplasty right out of the gate? And the reason is, compared to our older patient population, these young patients with symptomatic glenohumeral osteoarthritis have been shown to have worse survivorship. And it's primarily due to glenoid component loosening. In this paper that was published in JBJS by the folks out at Mayo, that specifically looked at 33 patients who were treated with shoulder arthroplasty for arthritis after instability surgery, their cohort had a mean age of 46 years, and they described an incidence of almost 40% failure of the glenoid component at midterm follow-up. So it leads us to this question that you see at the bottom of our slide here. Are there alternative treatments available to improve symptoms and function in the short term and hopefully delay or avert the need for a total shoulder arthroplasty in the longer term? And that's where we're going to go from here. So the crux of our talk is really the non-arthroplasty options for chondral lesions and glenohumeral arthritis in this young patient population. So Cole, Yankee, and Preventure at Rush published this paper in the Journal of Shoulder and Elbow Surgery, and they had this algorithm that you see here. And basically, if you find a chondral lesion incidentally at the time of arthroscopy, the recommendation is some sort of palliative approach, and that's an arthroscopic debridement. And if the lesion is bipolar, you can consider doing a capsular release. If it's more extensive and it's more of a bipolar glenohumeral arthritis than just an incidental chondral lesion, there was a period of time where this approach called biologic resurfacing was utilized. If we're talking about focal lesions affecting either the humeral head or the glenoid surface, if the lesion is small, you can consider a reparative approach like a microfracture, similar to what we're doing in the knee. Or if it involves the underlying subchondral bone, you can consider more of a restorative approach with an osteochondral plug transfer, whether it be an autograft or an allograft. For larger lesions, the restorative approach for either the glenoid or the humeral head can be some sort of cell-based cartilage repair, like an autologous chondrocyte implantation, or more recently, a MACI or matrix-associated chondrocyte implantation. And for larger lesions that involve the underlying bone, you can do some sort of bulk osteochondral allograft as a reconstructive treatment approach. So what we're going to do is kind of go through each of these approaches with their pluses and minuses and what available outcome data there is. With respect to the arthroscopic treatment, debridement and capsule release of the glenohumeral joint has been shown to have high levels of satisfaction in the 80 to 90% range in the literature, but the problem is this benefit lasts in only the short term, most reporting a benefit for 2 to 3 years or up to 5 years. So in this initial paper that you see that was published in Arthroscopy, that was a retrospective analysis of the arthroscopic management of glenohumeral degenerative disease at a Rush, they were performing a extensive chondroplasty of both the articular surfaces and the labrum, and a circumferential capsule release, including the rotator interval, which has been our approach, my approach, with the patients that we're seeing with this condition here at NYU Langone Orthopedic Center. Dr. Millett out of Vail, as you see in the paper on the bottom, describes what he calls the CAM procedure, and that's a comprehensive arthroscopic management for young active patients with advanced shoulder osteoarthritis. So in Dr. Millett's CAM approach, it includes a rotator interval release, an extensive chondroplasty and labral debridement, a resection of the inferior humeral head osteophyte, which is performed under fluoroscopic guidance, a circumferential capsule release, a careful axillary neurolysis, and a synovectomy, plus or minus biceps tenodesis or subacromial decompression based on that particular patient's presentation. And similar to what we had discussed, the outcomes that have been reported by these groups show really high satisfaction rates and improvements over preoperative baseline, but the efficacy and the benefit is relatively short-lived. So if we're talking about more of a focal defect affecting either the glenoid or the humeral head, similar to what we would do in the knee, you can consider a microfracture. And the concept here is utilizing a curved awl, as you see here in the image on the bottom right. We penetrate the subchondral bone plate to cause bleeding in the base of the defect. A fibrin clot forms, and mesenchymal cells from the bone marrow will then migrate into the clot and form a fibrocartilaginous repair tissue. While it's not articular or hyaline in nature, the repair tissue can lead to a more congruent articular surface, which can help with distribution of weight-bearing stresses. And compared to microfracture in the knee, microfracture in the glenohumeral joint is actually quite effective. And here's an example of a paper that looked at 18 patients treated with glenohumeral microfracture between 2001 and 2007. And while 3 patients did fail, ending up requiring a total shoulder arthroplasty, in the 13 patients that were available at final follow-up at a mean of 28 months, there were significant improvements compared to preoperative baseline with respect to their VAS pain score, their simple shoulder test score, and their ASES score, with more than 90% of the patients surveyed reporting that they were satisfied with the postoperative results and their postoperative functional abilities. When we get into dealing with cell-based cartilage repair of either the humeral head or the glenoid, we're really limited to only small case reports in the literature. So here's an example of a autologous chondrocyte implantation for a surface lesion of the humeral head. And when I mean surface lesion, it means that just the overlying articular surface is involved with a preserved subchondral bone plate and little to no subchondral bone marrow edema present, similar to our indications in defects of the knee. As you see here, it is a procedure that requires an open approach. The defect is turned into a circular or elliptical lesion. And in this case with ACI, which was second generation ACI, basically a collagen patch was sutured over the lesion site, and the patient's cultured chondrocytes were injected underneath, covered in a fibrin glue. The more recent approach here is utilizing MACI, where the patient's cells are seeded onto a collagen matrix in the lab, and that seeded matrix is implanted at the base of the treated lesion with the idea that the matrix will grow from bottom up to fill that defect and restore a more normal articular surface. For larger lesions and those that involve the underlying bone, you can consider an osteochondral allograft implantation as you see here. We utilize a sized matched humeral head allograft. The defect site is cored utilizing a reamer, and a matching dowel is taken from a region of the humeral head allograft that will allow us to implant that dowel to restore an articular surface and a more congruent and normal radius of curvature, which can improve both pain but also stability. We've been utilizing this approach for large hill sacks and reverse hill sacks with excellent outcomes. It is an open procedure, but once implanted, it can really restore a more normal appearing articular surface of the humeral head. The outcomes that have been reported in the literature are relatively limited. In this first paper that was published in AJSM, they looked at 20 fresh humeral head allografts implanted between 2003 and 2010. They found that on postoperative imaging, all of the allografts had integrated well, and compared to the preoperative baseline, there was significantly reduced pain and improved range of motion. In the bottom paper, which was a systematic review published in Arthroplasty by Saltzman, they looked at 12 studies where 35 osteochondral allografts were implanted, mostly for Hill-Sachs lesions. What's important to note is that in many of these studies, the allografts that were implanted and utilized were not fresh, which led to a relatively high incidence of graft resorption and consequent reoperation, mostly for debridement and graft removal. So the recommendation here is if you're going to utilize an osteochondral allograft, it should be a sized, matched, fresh allograft to ensure that it's going to incorporate and integrate with the host tissue. Well, what about the glenoid? Virtually all the literature indicates that the results of glenoid replacement are superior to humeral head treatment alone. So we know that the glenoid articular surface is important. We discussed the fact that microfracture of the glenoid is a treatment option that has shown promise with respect to successful clinical outcomes. But you also can utilize an osteochondral allograft, as you see here in the case that was provided to us from our colleague Ruben Gobezi in Ohio. It is an open procedure, and this particular allograft utilized a medial tibial plateau from a donor. And the idea here is that the medial tibial plateau provides a radius of curvature and a concavity that's similar to the native glenoid. And as you can see, it is restoring that glenoid surface with healthy, mature, articular surface capable of withstanding the glenohumeral loads. When we're dealing with a patient with more extensive glenohumeral arthritis, there was a period of time where biologic resurfacing of the glenoid was thought to be a good treatment option. This approach was first proposed by Burkhead and Hutton in 1988. And the concept is basically what you see here in this image in the center, where a hemiarthroplasty is used to treat the humeral head, and some sort of interposition over the glenoid is implanted. It could be anything from Achilles allograft to fascia lata to a dermal allograft, as you see here on the right. But the most commonly utilized interposition was a folded over lateral meniscus allograft, which is then sutured to the remnant native labrum. There's an extremely large variation in outcomes that are reported in the literature following biologic resurfacing. In Krishnan and Burkhead's paper that was published in JVJS in 2008, they reported a greater than 80 to 85% success rate at almost 10 years of follow-up. While in contrast, the folks at Harvard, in their series of patients that were less than 50 years of age at the time of biologic resurfacing, they described a 90% failure rate at less than 2 years of follow-up. The folks at Rush, where I did my sports medicine fellowship, published this paper in the Journal of Shoulder and Elbow Surgery looking at 30 patients who underwent biologic resurfacing of the glenoid using a lateral meniscus allograft, as you see here in the image in the center. At 18 months postoperatively, the authors reported significant improvements in pretty much every measured outcome parameter, and 94 of their patients were reportedly satisfied with their clinical outcomes post-procedure. As a fellow at Rush, I started to see these patients further along in their follow-up with a rapidly diminishing clinical outcome, which led us to revisit the outcomes of this procedure at longer-term follow-up. We included 31 patients who had undergone biologic resurfacing utilizing a lateral meniscus interposition, and a cohort of 10 patients where the glenoid was resurfaced with an allograft dermal matrix. As you can see in these Kaplan-Meier curves on the right, the outcomes diminished very rapidly, with a 45% failure rate of the lateral meniscus interpositions at 3.5 years, and a 70% failure rate at a little more than 2 years in those treated with a dermal matrix allograft. We followed 7 of these failed biologic resurfacing patients as they were converted to total shoulder arthroplasty. As you see, there were 7 patients, 5 males and 2 females, whose initial diagnoses are as you see here. There were 3 patients with primary glenohumeral OA. There were 3 who had developed OA after a traumatic event, and 1 patient who developed glenohumeral arthritis secondary to an intra-articular pain pump. The conversion from failed biologic resurfacing to a total shoulder arthroplasty was performed in a mean of 2 years following the index procedure. What hopefully you can glean from the 2 graphs here is that with respect to the clinical outcome scores that we recorded and the postoperative range of motion, no significant improvement was seen following the conversion to total shoulder replacement. The average converted patient was considered to have failed both the resurfacing and the salvage total shoulder arthroplasty at the time of their final follow-up. So what about a truly biologic arthroplasty? And this is a relatively rare procedure with only a few cases that have been reported in our literature. And the concept here is in a very young patient where you want to basically look for something that has high risk but high reward. You resurface the humeral head with a bulk allograft, as you see in the image here on the left, and you resurface the glenoid with that folded over lateral meniscus allograft. And in the paper that was published here in the Journal of Shoulder and Elbow Surgery, this particular patient had regained full range of motion and had significantly improved functional outcome scores in pretty much every outcome score that was assessed. We are continuing to look for future treatment options for focal lesions, especially the glenoid. Here's a paper that we're working on looking at what's called the AMIC procedure. And the idea is that a microfracture is performed for a focal lesion and a well shoulder lesion in the glenoid, and that microfracture is covered with a collagen matrix, whose implantation is done in hopes that it can kind of steer the repair tissue to more hyaline-like repair tissue rather than a fibrocartilaginous repair tissue. We're currently assessing the histologic results of our rabbit model, which we performed the procedure in 30 specimens, and the early outcomes are relatively promising. So to kind of pull it all together, what I've hopefully presented is, and which you all acknowledge, is that young active patients with symptomatic glenohumeral arthritis are truly a treatment dilemma. And it's because they're young, they have high functional demands, and we know that historically, the worries about glenoid component loosening have limited our desire to utilize a total shoulder replacement amongst these patients. As you've seen, non-arthroplasty options are available, but they really are limited. The arthroscopic debridement and capsule release, or Dr. Millett's CAM procedure, is effective, but the benefits are relatively short-lived. While cartilage restoration of the humeral head and glenoid is possible with similar techniques as we're using within the knee joint, the outcome data is very limited, as most of the reports in the literature are single cases or small case series. What I hopefully got across is biologic resurfacing, where we're utilizing a hemiarthroplasty with some sort of interposition of the glenoid, doesn't work and may impact future arthroplasty. And for our young patients who truly are looking for that high-risk, high-reward approach, a biologic joint replacement is possible, but the outcome data is also very limited. So that brings me to my next question. We know in this depiction of survival free of revision following total shoulder arthroplasty and hemiarthroplasty in Sperling, Cofield, and Rowland's assessment of hemiarthroplasty and total shoulder arthroplasty in patients 50 years old or less, it begs the question, despite its limitations and concerns over glenoid component loosening, should total shoulder arthroplasty still be a first-line treatment for this patient population? And that's a question that I'm hoping that my fellow members of this panel will address, as the current options with respect to cartilage repair and restoration do remain relatively limited. And I'm going to ask Tyler just to show you all the video here on the left, which shows an arthroscopic view of a failed biologic resurfacing using a lateral meniscus allograft transplantation. As you see, you can see the hemiarthroplasty at the top, and you can see that the lateral meniscus allograft has truly disintegrated and looks quite terrible, with eburnated glenoid bone present at the base and very frayed remnant lateral meniscus allograft tissue. So this is truly a failure, and as we showed, can impact the outcome of a future arthroplasty utilized as a conversion. So I appreciate your time. and I'm happy to answer any questions that you may have on the non-prosthetic approaches to these young patients with glenohumeral arthritis.
That's an excellent presentation, Dr. Strauss. In the interest of time, we're going to keep moving, and if there's a question that comes along from the audience, we'll definitely pass it on to you. We're going to move to the second presentation. Humeral stem options in shoulder arthroplasty, stemless, short stem, or stemmed arthroplasty. My disclosures are available on the AAOS website. There's no conflict of interest associated with this presentation. The goals of total shoulder arthroplasty are to relieve pain and improve motion and function of the shoulder. Total shoulder arthroplasty relies on the principle of replace what you cut and restore soft tissue tension, which means that you remove the bone and replace it with the prosthetic implant, restoring the native anatomy and mechanics as close to normal as possible. This requires understanding of the anatomy and mechanics of the shoulder and its variation in normal population and in diseased shoulders. There is considerable variation in the morphometric parameters of normal and arthritic shoulders, and it is important to understand this variation in order to recreate patient-specific glenohumeral anatomy during total shoulder arthroplasty. Humeral stem designs in total shoulder arthroplasty continue to evolve. There have been many modifications over the last several decades with the intent to improve the ease of recreating proximal humerus anatomy, the ease of insertion, and the ease of future revision. In this talk, I will go over the modifications in the humeral stem over the last few decades and their current use in 2019. We all know that 90% of the proximal humerus can be modeled as a sphere, and the humeral head constitutes 1/3 of this sphere. This anatomic feature was incorporated towards designing the first humeral stem by Dr. Neer, which was a monoblock stem initially used for fracture stems, was non-modular, had limited sizes available. It was a thin polished stem which was used in a cemented fashion. With this stem, it was challenging to recreate proximal humerus anatomy and soft tissue tension in some patients, and this led to the introduction of the concept of modularity. The concept of modularity was incorporated in second-generation humeral stems with modular head and stem sizes. This resulted in multiple sizes for the head and stem, allowing the surgeons to mix and match. The head was suspended from the collar with a taper lock mechanism. Although the second-generation stems had advantages compared to the first one, but even with the second-generation stems, it was difficult to recreate the proximal humerus anatomy in certain cases. In late 1900s, there were considerable improvements and developments in the understanding of the proximal humerus anatomy, which led to the development of third-generation stems. Understanding of the humeral head offset in medial, lateral, and anteroposterior plane allowed more anatomic placement of the humeral head component. Multiple anatomic and imaging studies demonstrated that there is considerable variation in the proximal humerus anatomy in normal and arthritic shoulders. This led to the introduction of concept of adaptability, which was incorporated in third-generation humeral stems. The third-generation stems have modular anatomic designs and have the ability to replicate patients' version and inclination in the humerus using an inbuilt adaptability in the system, which could be in form of a dial-in mechanism or use of a replicator plate that allows you to match patient's native anatomy with the implant after inserting the stem. With the advent of reverse total shoulder arthroplasty, fourth generation stems were introduced. These convertible stems allow converting an anatomic to a reverse system inside without taking out a well-fixed stem. As you can see, stem humeral components have an established track record of success and a very low rate of loosening and subsequent revision. However, there are limitations with stem components. They violate the medullary canal and can have stem-related complications, including intraoperative fractures and stress shielding proximally. Moreover, revision surgery can be challenging in a well-fixed stem due to risk of fracture and humeral bone loss during removal of the humerus component. Stem components can be particularly challenging to implant in clinical situations like post-traumatic deformities like tuberosity or shaft malunions. Short stem components were introduced to offset some of the limitations that were mentioned with the standard length components. Short stem designs are more anatomically shaped with a proximal metaphyseal fit. They're more bone preserving with relative ease of revision compared to the standard stem. Short-term data with short humeral stems demonstrates clinical and radiographic outcomes that are very comparable to the standard stem. However, short stems also have limitations that were associated with the standard stems. They do violate the medullary canal and can have stem-related complications, including intraoperative fractures and proximal stress shielding. In addition, fixation in osteoporotic bones may be compromised due to poor bone stock in the metaphysis. There has been increasing interest in stemless design recently, with multiple design options available on the market for stemless reconstruction. The stemless design relies on fixation in the metaphysis at the head-neck junction of proximal humerus. They replace humeral head without violating the medullary canal and are more bone-sparing than stem components. They allow easy reconstruction of proximal humerus with relative ease of revision. Intraoperative or postoperative fractures can be bypassed with a short or a standard stem component. However, there are certain disadvantages associated with the stemless design. There's a risk of lateral cortex fracture. Radiolucent lines have been reported around the fins of the stemless design, and we still don't have long-term follow-up data on stemless designs. The evidence is out there, but it is short and midterm, with the results comparable to the short and standard stems. The radiolucent lines around the fin and lateral cortex fractures that have been reported are legitimate concerns, but they have not been correlated to loosening at short or midterm follow-up. And we'll talk more about that in next subsequent slides. Last but not the least, the resurfacing design, partial or total resurfacing designs rely on fixation in the humeral head. Like the stemless design, they do not violate the medullary canal and are particularly useful in focal humeral defects. However, there's risk of overstuffing and malalignment, especially with total resurfacing of the humeral head. In addition, surgical exposure for glenoid resurfacing can be particularly challenging with resurfacing designs due to humeral head in the surgical field. So let's go to the evidence of stemless versus stem. There are mainly short and midterm follow-up studies that demonstrate that there are no differences in the functional outcomes and revision rates between the stemless and stem components. Rasmussen et al. Published their data from the National Registry that was contributed by Norway, Finland, Sweden, and Denmark with patients enrolled between 2011 and 2016. They compared 761 stemless designs to 4,398 stem components. Their 6-year cumulative survival rate did not show any difference between the stemless and stem design, and there were no differences in the revisions noted. The other studies are relatively short-term follow-up, but in stemless and stem designs, and none of them have shown any significant difference in the revision rate or survival rate for these components. Stemless designs are definitely associated with less blood loss because they do not encroach onto the medullary canal. They have shorter operative times and less proximal shielding. So the question is, does the length matter? As we go from the standard stem to the stemless fixation, there are numerous advantages that are encountered. There's more preservation of the bone stock. There's no violation of the medullary canal with less risk of stem-related complications. And there is a relative ease of future revision because the implant size is smaller and diaphyseal or metaphyseal encroachment is relatively less. But this could come at the expense of fixation. We don't know yet. With stemless implants, we are relying on metaphyseal fixation in the neck and proximal metaphyseal region, which may not be as good as the fit that is obtained with standard stem, which is in the diaphysis with or without cement. This would particularly be true in patients who have osteoporosis or have inflammatory arthritis in which the bone stock in the proximal metaphysis is not very good. As you can see in this slide, as we move from standard stem towards the resurfacing and stemless designs, we are preserving bone stock, we are moving away from the cement. And definitely this would correlate with ease of revision, and short-term and mid-term data is showing that there is comparable implant longevity and survivorship. This would be particularly helpful in young patients with good bone stock, as these designs will allow us a relatively easier humeral-sided future revision surgery. However, we all know that glenoid is a bad actor in total shoulder arthroplasty most of the time. Humerus side is less common of a weak link, and cost effectiveness of these innovations have yet not been tested and would be an important thing to look into. In conclusion, humeral components continue to evolve. Stemmed humeral components have an established track record of success. Stemless technology is new, with advantages of easier recreation of proximal humerus anatomy in total shoulder, preservation of bone stock, and future ease of humerus-sided revisions, making it really attractive option in young patients. But there's a logical concern for stability of fixation, and we need to wait for long-term data before we say that short stem or stemless designs are relatively superior to the standard stem. To sum it up, my current indications for selecting a humeral component is as follows. I choose partial humeral head resurfacing when I'm dealing with focal chondral defects. I go for stemless design in patients who have good bone stock and head-neck junction. These are typically young patients with primary OA or with AVN, in which the bone at the head-neck junction is not compromised by the AVN process. I use short stems for majority of my patients who have good metaphyseal bone stock, and I reserve long stem only in cases where I cannot do a short stem, or if I'm doing a revision surgery from a stemless to a short stem. Thank you very much for your patient listening, and we'll look to see if there are any questions for the panel. If not, then we'll move on to the next speaker, Dr. Kwon.
Hello, can you put my slides up, please? So while the slides are bringing up, I also want to thank Dr. Virk for organizing this the webinar. This is the first time I'm using the webinar, so if there's some technical glitches, my guess is the majority of that is going to be from me and not from our good folks who are running the program. That being said, I have been tasked to give a talk on the expanding indications for the use of reverse shoulder arthroplasty. My disclosures are that I do work with a company that manufactures one of these components and prosthesis. So the concept of a reverse or constrained shoulder arthroplasty is not a new one. It was tested as early as the 1970s. In those days, some shoulder surgeons thought that they would be able to adapt designs from a total hip arthroplasty and design a constrained shoulder where the humeral component would be essentially locked into the glenoid component. Majority of these were considered experimental. Some actually did okay. However, majority of them failed, with some of which quite catastrophically, and majority of the failures occurred on the glenoid side. Then came along Paul Grumman in sort of the early to mid 1980s. Paul Grumman came up with a design, and he wanted to essentially improve this concept of a constrained shoulder replacement system, where you could restore the stable fulcrum for rotation of the shoulder while minimizing the fixation, while minimizing the failure of fixation on the glenoid side. So he came up with a quote that says that he would like to design a prosthesis that relies solely on the deltoid for both movement and stability. He did come up with a various prosthesis. The prototype, the very first prototype, as you see on the left side here today, is 2/3 of a spear using a ceramic. It was to be implanted onto the glenoid using cement, and it was fairly large, about 22 millimeters in diameter. This was never actually inserted into this patient. But he did design an updated prototype, his second prototype, which you see here on the right. At this time, similarly, he used 2/3 of a spear, but this was slightly smaller, 36 millimeters, and was made of metal. It was fixed to the glenoid using cement and was actually implanted into a few patients. Unfortunately, however, this patient also failed as well. Dr. Grumman then went on to design his third generation prosthesis, a third prototype, and this actually worked very well. So on the glenoid side, he changed the sphere from a 2/3 of a sphere into 1/3 of a sphere, and what that allowed was that it placed the center of rotation directly against the glenoid surface, thus minimizing the shear forces against the prosthesis. In addition, he put a larger diameter to provide stability to the joint, and then used a metal component that could be inserted and fixed to the glenoid using screws rather than cement. On the humeral side, he made the humeral cut to be cut with a high inclination, which means a little more horizontal cut, which allowed pre-tensioning of the deltoid and which then minimized impingement during elevation. This system, like I said, worked very, very well. And for a majority of the patients that saw fantastic results that we did not envision in the past. The system was introduced in Europe in 1991, and after great results, they were then brought over to the United States with FDA approval that was obtained in late 2003. And basically, it was in early 2004 that all of us were starting to use this prosthesis. Since then, the reverse has essentially driven the market for total shoulder arthroplasty, certainly in the United States and most likely around the world. As you can see here, that the graph clearly illustrates the overall usage of total shoulder arthroplasty has increased dramatically, majority of which was due to the utilization of the reverse shoulder replacement. So this is the initial Delta 3 designed by Paul Grumman, and since then, there have been many, many other prostheses that have been designed, all of which utilize similar concepts that Dr. Grumman solved. So at the latest count, I believe there's somewhere between 18 to 22 different reverse replacements around the world from various manufacturers. So about 10 years ago, when I gave a similar talk, we would talk about some of the indications for reverse replacement. At that time, really the only accepted indication was patients who were suffering from rotator cuff dysfunction. That is, older patients with rotator cuff arthropathy or those patients with painful and irreparable rotator cuff tears. Since then, and or at least at that point, other sort of debatable indications for reverse replacements included treatment with proximal humerus fractures or revision shoulder arthroplasty. Now, 10 years later, those indications have clearly expanded. So rotator cuff dysfunction, proximal humerus fractures, revision shoulder arthroplasty, as well as fracture sequela are clear indications for reverse replacement with much literature to support the use. In addition to that, there are now coming some more debatable indications, including glenohumeral arthritis with intact rotator cuff, as well as patients with chronic shoulder dislocations. So we'll talk about all these indications sort of separately. This is my very first patient that I used a reverse replacement on. This is a 70-something-year-old lady who showed up with these x-rays, basically unable to raise the arm, clearly demonstrating shoulder paralysis. Her MRI demonstrates that she doesn't really have much of a rotator cuff there. The supraspinatus and the infraspinatus are clearly gone, and there's no remaining muscle. And this is the very first reverse replacement I inserted. Once again, the Delta 3 design. The patient then came back to see me about 10 days after surgery, essentially to have the sutures removed. She has not officially started her supervised therapy yet. She comes in, I ask her, so how are you doing? And she says, I'm doing fine, and raises her arm like this. And this is when I was convinced that reverse replacement clearly does work and that I'm going to be using the prosthesis a lot more frequently. There's lots of literature about the use of reverse replacement for patients with rotator cuff dysfunction. There's one of the original articles from Europe demonstrating that 80 patients at around 3.5-year follow-up had good outcome in terms of pain relief, as well as average elevation that went from 70 to 140. The constant score, this was an absolute constant score that went from 23 to 66, which would be regarded to be at least a good, almost excellent outcome. More recently, Mark Frankel wrote his experience of 114 shoulders that were treated with reverse replacement for rotator cuff dysfunction. At a minimum follow-up of 2 years, they had at least satisfactory results in 94% of the patients, average elevation going to 120 degrees, and an average ASS score going to 78. Once again, this would be considered at least a good outcome. The next indication for reverse replacement that is no longer debatable at this point is use for treatment of proximal humerus fractures. About 10 years ago, like I said, this was debatable because at that point, probably the gold standard for treatment of proximal humerus fractures that cannot be reconstructed would be to use hemiarthroplasty. Patients who are treated with hemiarthroplasties for proximal humerus fractures generally demonstrated good pain relief. And because of that, many thought the patients had reasonable outcome. That good to excellent outcome was reported in about 3/4 of the patients, and the average constant score was about 60. However, there was a significant variability in the outcome. That is that there are many patients who did very well with the constant scores in the 80s, and many patients who then did very poorly in the constant score of 40s. And the results also deteriorated slowly over time as well. So a case example is this patient of mine. She was a 70-something-year-old lady who had proximal humerus fractures, who was initially treated with hemiarthroplasty. You can see at 6 months, she's able to raise her arm. You can see the tuberosity, and she was doing well. At 12 months, she could still raise the arm, but I was getting a little concerned because the tuberosity, if you could see, is no longer visible at this point. At 18 months, tuberosity is completely gone. She cannot raise her arm very far. And in addition to that, the humeral head is starting to ride a little bit high. So in such a case, I had to convert her to a reverse replacement, and she was then able to do fairly well with active elevation to about 160 degrees. So because of this reason, people were starting to use reverse replacement. The first head-to-head study that compared the hemiarthroplasty versus reverse for proximal humerus fracture was this one in 2009. It was a fairly small study with 16 and 17 patients in each group with a very short follow-up of only about 1 year. However, even at this point, you can see that the average elevation for reverse replacement was slightly better, as well as the overall constant score, which was also better. More recently, our colleagues from Spain published this article. This was a prospective randomized study. So once again, this was a much better study. They compared patients who were treated with reverse versus hemiarthroplasty for proximal humerus fractures, and basically on all outcome parameters, including the DASH score, average elevation, adjusted and non-adjusted constant scores, demonstrating improvement and superiority for the reverse replacement. Therefore, at this point, I clearly believe that the gold standard for treatment of proximal humerus fractures that cannot be reconstructed is probably a reverse replacement. Next indication is a revision arthroplasty. So a case like this one, this is a patient who had hemiarthroplasty for proximal humerus fractures that clearly failed. So let's see if I can skip the. Okay, so we decided to treat the patient with a reversion replacement using a reverse construct, as you see here, with a significant amount of bone graft that required. The patient then actually did okay. She had a good pain relief, and she was able to elevate the arm to about 90 degrees, so the patient was reasonably happy. We wrote up our arcs, or in another case like this, where a patient was treated with an anatomic shoulder replacement for glenohumeral arthritis. Initially, the x-rays looked great, and the patient seemed to be making progress. Then subsequently, however, the patient started doing poorly, and you could see on x-rays that the humeral head is riding high, and also it's starting to escape anteriorly. The patient's rotator cuff had torn and went into a rotator cuff dysfunction. Therefore, this patient then had to be converted to a reverse replacement as well. We wrote up our experience a number of years ago at NYU Langone Medical Center, describing our patients who were treated with reverse shoulder replacement for failed hemiarthroplasty and anatomic shoulder replacements. We had 28 patients that we followed for about 3.5 years. The overall outcome was satisfactory in about 82%. Average elevation did go up to about 100 degrees, and AS score to about 66. Mark Frankel wrote about his experience with patients that he treated for a failed anatomic total shoulder replacement. He had 24 patients at a minimum 2-year follow-up with at least satisfactory outcome in about 91%, average elevation to 130, and ASS score to 68. He also did note, however, that there was a fairly high complication rate, majority of which were dislocations. So with high complications rate being 23%, and he did recommend caution in proceeding with this surgery until it is absolutely necessary. Another indication for reverse replacement that is no longer debatable is a fractured sequela. Certainly, a patient shows up with a fractured non-union like this one. The treatment options are fairly limited. This patient showed up to my office without being able to raise her arm and complaining of significant amount of pain. I then treated her with a reverse replacement. I would like you to notice here that I did maintain the tuberosity right here and incorporate it into the overall prosthesis. At 1 year, the greater tuberosity had healed in, and she was able to raise her arm to about 170 degrees. I'd like to also point out, however, that this patient, despite the fact that she was able to raise her arms to about 170 degrees, she was actually still unhappy with her shoulder, as her yoga poses were apparently not quite symmetric, so she was still a little bit upset with her results. Okay, so in the literature, Mark Frankel once again wrote about his experience treating patients with proximal humerus malunion with reverse replacement, average elevation going to about 100 degrees, and that ASAS score including the 63. So clearly these patients were doing much better. In addition to that, there was a multi-center study that was published in 2014, 32 shoulders with surgical non-union, so similar to the case I just presented, where the average elevation went to 110 degrees and constant score to about 47. So this would be considered a fair outcome. What they all did also know was that there was a significant complication rate of about 41% with revision surgery and about 28%. What the authors noted was that if the tuberosity is not maintained and just resected from the final construct, then the patient generally do not do well and were at a significant risk for subsequent dislocations. Now to more debatable indications. So this is a patient of mine. So it's a patient who had clearly glenohumeral arthritis. His rotator cuff is intact. You can see right here that his glenoid has significant erosion. On a CT scan, you can see that this would be a type 3 type of glenoid deficiency with significant humeral head posterior subluxation as well as posterior glenoid bone loss. How would you treat this patient? Well, there has been some literature on this already. Charles Walsh wrote about his experience on 92 patients that was treated with anatomic replacement for shoulder arthritis. If the patients did have biconcave glenoid, about 16% required revision at about 7 years, and there was about 21% glenoid loosening. What was also alarming was the fact that the degree of glenoid loosening clearly correlated with the degree of bone loss that was seen on preoperative X-ray. So degree of bone loss and humeral subluxation was clearly correlated. So going back to this patient here that I had with significant glenoid bone loss, I decided to instead treat the patient with a reverse replacement. There is actually bone graft in the posterior aspect of the glenoid that you can't see quite as well on the axillary view, but certainly on the AP view, you can see the bone graft that's clearly present. This patient ended up doing fairly well. So this experience was also written up and published by Charles Walsh, where he treated 27 patients with osteoarthritis and intact rotator cuff, but he treated them with reverse replacements due to the significant amount of bone loss on the glenoid. These patients had significant bone loss, including up to 32 degrees of retroversion. So many of these patients did require bone grafting. However, the patient did fairly well with average elevation to about 152 and constant score of 76. There were 4 complications, but only 1 revision surgery was required at this point. So the question now is, what would you do for a patient like this? Once again, this is debatable. When we're now talking about a 74-year-old woman with arthritis, intact rotator cuff, or as far as you could tell, clearly it's bad arthritis, but the glenoid does not have significant bone loss, and the humeral head is not posteriorly subluxed. I think this is debatable. Certainly, patients who are older with questionable rotator cuff, most of us would put in a reverse replacement. If the rotator cuff is pristine, many of us probably put in an anatomic replacement, although there are some surgeons around the country who would even preferentially put in a reverse replacement, even if the rotator cuff is pristine. So this is certainly a debatable indication at this point. The last debatable indication is chronic dislocation. So the potential advantage of using a reverse for dislocation of shoulder or for an unstable shoulder is quite evident. It is a constrained construct, so there's inherent stability between the glenoid and the humeral component. In addition to that, as we have just demonstrated, the reverse replacement could clearly compensate for damage to the rotator cuff and also to the damage or defect about the glenoid bone. So there is a clear benefit of using the reverse for patients with such bad shoulders. As you can see an example here, there's a patient of mine who had a hemiarthroplasty for proximal humerus fracture, which is now dislocated. Clearly, the humeral head is now sitting out of the socket. You can see that also on the CT scan. So this patient I decided to treat with a reverse replacement. You can see on the left side, the native bone had a significant amount of anterior glenoid bone loss. So I had to fill that with bone graft and then prepare for reverse replacement. The patient was able to raise arms to about 85 to 90 degrees and had minimal pain. So the patient was fairly satisfied with this result. This year, Christian Gerber wrote about his experience with 11 patients who were treated with reverse replacements for a chronic dislocation. He followed these patients for about 6.5 years and noted that the patients did fairly well. Now, they do have some controls. So these were patients, the match controls were patients who were treated with a reverse replacement for rotator cuff dysfunction. In comparison to those, these patients did not do quite as well. So their average elevation was 110 degrees and constant was 64. But still, that would be considered a reasonable outcome. And in addition to that, the authors noted that there's no postoperative instability episodes, including dislocation. So this is another one of those chronic dislocation. The chronic dislocation would be another debatable indication for the use of reverse replacement. So in conclusion, we could certainly see that the number of indications for the use of reverse replacement have clearly expanded. and that has driven the use of reverse replacement. In fact, at this point, reverse replacement is probably has outtaken the anatomic replacement for popularity. What we need to understand, however, that the reverse replacement is associated with higher rate of complications. Depending on some of the studies that you read, the rate of complication is high as 50%. In addition to that, I'd like to also mention the fact that we need to also remind ourselves, that the long-term data for reverse replacement is still lacking. We've been using this in the United States really only for past about 14 to 15 years. It doesn't have the 20 to 30-year data that we see for other replacement systems. So an analogy I'd like to present is something that others have told me, which is that, when you have a good hammer, it works well, everything's going to look like a nail. And I just wish that we kind of progress a little slowly and really try to go by the available literature before jumping on the bandwagon. Thank you very much.
Thank you, Dr. Kwon. That was an excellent talk. I have a question from the audience for you, and the question is, what do you do with the rotator cuff muscle during reverse total shoulder arthroplasty? And I think they're trying to ask whether you repair subscap or not, and do you ever sacrifice supra or infra during the approach if you see a very tight shoulder?
Yes. So the answer is yes and yes. So the short term is that whenever I can, I try to repair all the rotator cuffs that are available to repair. So certainly subscapularis is a tendon that I believe is beneficial to repair, and I think it does provide additional stability, although that topic is about somewhat debatable at this point in the literature. The second part is that if I'm putting a reverse replacement and there are some intact rotator cuff that causes the shoulder to be so tight and prevents adequate surgical exposure, I will also do some release as well. That's pretty rare for that to happen. Only time that really presents itself would be on a revision case. If you are trying to revise a failed anatomic replacement into a reverse and you want to maintain the humeral stem, many times in order to get the additional length, you do have to sacrifice the supraspinatus, or at least some portion of the supraspinatus.
Thank you very much. We're going to move on to our last speaker, Dr. Zuckerman, in the interest of time, and then we'll take questions as they come along at the end.
Okay, thank you, Dr. Virk. So that's the last slide in my talk. So we have to go to the first slide. Okay, there we go. Good. So my topic is to talk a little bit about guidance technology in shoulder arthroplasty, specifically the indications in my early experience. My disclosures are significant since I am a design surgeon for Exactech for a shoulder arthroplasty system, and the guidance technology that I'm going to describe is made by Exactech. So you've heard from some of our previous speakers, performing a shoulder arthroplasty is a challenging surgery. It's challenging because there are relatively limited bony landmarks. We're basically working in somewhat of a deep hole with a small area of the bone, particularly the glenoid. And I found through the years that I've been doing this that there's an important learning curve that takes place for any shoulder arthroplasty surgeon. And that learning curve can be short or longer based upon frequently the complexity of the cases. Anatomic shoulder replacement has excellent results. You've already heard that from the other speakers, and there is a correlation between clinical outcomes and the ability to reproduce the anatomy. This is certainly true with anatomic replacement. Obviously, it's not as significant as with reverse replacement, but on the anatomic side, it's very important. And the real issue for me is, I think most surgeons, is the glenoid. You know, the exposure and the limited visualization of the glenoid, in other words, just the surface of it, it makes it difficult to precisely determine some of the anatomic landmarks, specifically Friedman's axis, the central line of the glenoid component, and looking at the glenoid en face, determine the glenoid version or the orientation of the glenoid component, even when integrating preoperative imaging studies, can be a challenge. And to me, right, what you see in the glenoid is not necessarily what you get. There's a concept of face anatomy versus vault anatomy. You can see in the X-ray on the CT scan on the left that if you looked at that glenoid and divided into this mid portion in an anterior-posterior direction and decided to prepare the glenoid at that point for the glenoid peg, the central peg, you would basically perforate out the posterior portion because the vault is very anterior in relationship to the face, whereas the CT scan on the right shows a more symmetric relationship between the glenoid face anatomy and the glenoid vault anatomy. And there can be a great variation in this from one extreme to the other. So to me, shoulder arthroplasty is really all about the glenoid. And anything I can do to improve glenoid component selection and placement will allow me to achieve the goals of a successful outcome. Because if you understand glenoid anatomy and can reproduce the anatomy, glenoid fixation will probably be enhanced, which will have an impact on long-term survival. So there are three different areas that can be utilized. The preoperative three-dimensional planning can help you select position and the component. Patient-specific instrumentation allows you the intraoperative options, and then the preoperative planning combined with intraoperative navigation is the other option, the one I'm most familiar with. And of course, I would say that even though we're talking about the glenoid, it's only a matter of a relatively short period of time when navigation will be used for the humerus as well. So preoperative 3D planning was clearly an advantage the way we did it before. Now, how did we do it before? I mean, for years, I would get standard radiographs, including an axillary view, and try and discern glenoid anatomy. And then I decided, well, I'm going to get CT scans because it really helps me understand the anatomy of the glenoid. The problem is that so oftentimes I didn't get CT scans on all the patients I really should have gotten it on. So then I went to getting a CT scan on all patients before glenoid replacement. And that helped because really understanding glenoid anatomy is critically important to have the right imaging. The development of three-dimensional imaging on CT scanning was a help as well. So the ability to use this advanced imaging combined with preoperative planning is a benefit. It allows you to choose the center of the glenoid, Friedman's axis, and determine what position of version and inclination you want to shoot for in the operating room. Now, however, I would point out that this is a preoperative planning exercise that you now have to reproduce in the operating room. So therefore, patient-specific instrumentation took it one step further. It allowed you to take preoperative imaging and determine where you want to put the glenoid and have a patient-specific guide that allows you basically to prepare the glenoid for proper placement of the glenoid in the position where you want it to be. This is a little more complicated. It requires lead time, as many of these technologies do. There's additional costs, and there's certainly a risk of error. You know, I did a lot of patient-specific instrumentation in total knees, which were designed for the patients, and oftentimes there was a certain margin of error in the guides that you were given. And I think that this has been somewhat of a problem with this technology in some instances as well. So this took it further, but to me does not have the flexibility or the mid-course correction options that you would really like to see, which now brings us to the question is whether preoperative planning, with or without patient-specific instrumentation, is it ultimately going to provide evidence that the outcomes are better? And that's an unknown question for all of this technology. We think improved accuracy and placement will mean longer implant survival, but that remains to be seen for this technology as well as navigation technology. So the preoperative planning and intraoperative navigation combination is what I have found most effective and has actually made me a better arthroplasty surgeon. This is the system I use has a relatively compact touchscreen. There are small trackers that have to be placed within the operative field. But basically the steps are the same for the glenoid except for the placement of the trackers and the acquisition of the data. So this requires preoperative planning. The CT scan is required to generate the imaging data that can then be segmented. It usually takes a few days because it's done by an external company. And then it's sent back to me so I can incorporate it into the preoperative planning tool, which I'll show you. I make my decision about implant type and position, and then that's fed into the computer used during the operative procedure. So this is a video, shows you a little bit of the preoperative planning. So Tyler, can you just run the video here? Tyler? Okay. So this is a short video. You can see I can place the implant that I want on the glenoid face. I can move it anteriorly, posteriorly, up or down. I can change the size of the glenoid component. I can deepen it so I get good bony contact, just like that, right? And then, next slide, please. So let's run this video. It allows me to visualize the implant on the bone and adjust the positioning. And you can see this allows me basically to move it along because I get a cross-sectional anatomy, and I can scroll through it to see if in this one I'm too posterior, so I want to move it anteriorly to sit better in the vault, and this allows me to do so. Next slide, please. So again, let's run this video as well. So this shows you how you can position it, change the glenoid component, move it anteriorly or posteriorly, right, and get it positioned in exactly the position on the different planes. Now, I can check this in the axial plane, the sagittal plane, and the coronal plane and decide what position. Once I've decided on the implant and the position, I then save that, and I'm going to take that and transfer it to the computer. Okay, we can go back to the slides now. So, and then with this loaded into the computer, I basically can utilize the preoperative plan intraoperatively by acquiring the different points. It can allow me to determine version, inclination, placement on the glenoid, how much to ream, and in the case of reverses, allow me to place the screws at an optimal position. What's beneficial about this, there's a tracker that has to be placed onto the coracoid, which is fairly straightforward. The acquisition of the anatomic landmarks takes a relatively short period of time, but every other step is similar to a conventional shoulder replacement, whether anatomic or reverse, that I have been using previously. So I think this makes for a shorter learning curve than other potential techniques. Now, is this more accurate? Well, this was done in a cadaver study. You can see, asking the surgeon to place the glenoid in the proper position, the glenoid component, the blue marks are the variation without navigation, and the red ones are with navigation. You can see I got much closer to the 0 point, the desired point of inclination or version, retroversion or anteversion. So it is more accurate, at least here in a cadaver model. So let me tell you about my experience with intraoperative navigation. So I started using this technique in July of 2017. So it's just about 2 years ago. So we analyzed the 100 cases I did up to July 2017, and we compared it with the first 100 cases I did after July 2017 using navigation. You can see the difference in anatomic and reverse is just about the same, about 50-50, a little more reverse in the second group of 100. And the question I had on this learning curve study basically, what was the impact on my OR time, and what about implant selection now that I could more precisely understand glenoid anatomy and place the glenoid component in position? So you can see from this slide that without navigation, those 100 cases, the mean time was 106 minutes. With navigation in those 100, it increased 11 minutes to 117. Not a tremendous amount of time, but certainly, about 10 minutes longer per procedure. When you look at it more closely, of those 100 cases with navigation, you can see for the first 25 cases, the increased operative time was 13 minutes, but for the last 25 cases, the increased OR time was only 4 minutes. So clearly there's a learning curve, and I would say that learning curve is optimized somewhere between the 25th and the 75th case with this. Now, the type of glenoid component was selected was interesting. You can see without navigation for the 100 cases, 85 in the system I use, which has augmented glenoids for primaries and reverses, I did 85 used standard glenoids and 15 used some type of augmented glenoid. And the split between anatomic and reverse is shown here. However, when you look at the navigated system, it was much different in terms of appreciating glenoid anatomy and selecting an augmented component. In the 100 cases, 46 required an augmented component, and with respect to the anatomics, 20 out of the 46 were augmented, compared with 6 out of the 49 previously. And on the reverse side, 26 out of 54 compared to 9 out of 51 previously. And if you compare these two in this graph here, which is more easy to see, you can see there was quite a significant difference from 12% to 43% for the anatomic, and from 16% to the 48% for the reverses. And these results have been documented by some of my colleagues. Dr. Florin in France have found the same thing. With navigation, you are more likely to use an anatomically augmented implant. So, but what about the general experience with navigation? So let me say that basically I use navigation in every case now because I think it's been helpful. As I said, it made me a better surgeon. In this particular case, you can see how navigation in somebody with severely eroded bone allowed me to determine that I could implant a glenoid component, and in this case, an augmenting glenoid component, and put it down the glenoid vault in the position without perforation. If you look at this one, I've done 2 cases in which a pre-existing Latarjet screw, which was medial enough that could not be easily removed. The first one without navigation, and the second one with navigation. I spent a lot of time planning the case before I had navigation, and fortunately, I was able to bypass the screw. But it was much easier and more straightforward when I could do the similar procedure with a intraoperative navigation. And in this particular case, the ability to implant the glenoid in a severely eroded glenoid allowed me to make this decision preoperatively and then follow the operative plan. The interesting thing is that, although I don't have time to show it here, I oftentimes use this navigation in combination with planning the bone graft for severely eroded glenoids, and I think the navigation helps you plan the size and location of the bone graft as well. So the positives about intraoperative navigation combined with preoperative planning is that it does give you that continuum between the preoperative plan and the intraoperative implantation. I've found this system to be user-friendly. There's a relatively short learning curve, and I think I can reproduce the results. There are negatives. It does take more OR time, although it decreases with experience. And there is an increased cost per case, which ultimately has to be considered for the institutions where you work. And the longer-term question is it going to be worth it? Can we provide it? Right? Can we provide basically the information that the results that are needed? So, and those are the unknowns. Are we more accurate? And if we are accurate, will we have better clinical outcomes and longer implant survival? That's to be determined, and I hope to be able to present those results in the next few years. Thank you very much.
Thank you very much, Dr. Zuckerman. I have 2 questions from the audience, and some of them you have kind of gone over in your talk. But just for the completeness sake, one of the questions was, what are your thoughts about cost effectiveness of computer-assisted navigation and PSI? And I think you kind of touched upon it. If you want to, if you have any other thoughts on this particular question from the audience.
Yeah, all these systems, whether it be the preoperative navigation or PSI, they cost more money. I mean, if you don't get a CT scan on every system, on every case, then now you do need to get a CT scan. And the cost will vary. I think it's our responsibility to minimize the cost in whatever way possible, and also our responsibility to determine whether it's going to be worth the cost. Frequently in orthopedics, we make changes that are more costly without really deciding whether the cost benefit is there or not, because by the time we can do that, we moved on to something else. So I don't have an answer to that yet. I think it's going to be worth it. I will tell you that there's no doubt in my mind I am a better glenoid surgeon as a result of this system, and I think that's going to bear out in the clinical and the implant survival results.
There's another question from the audience asking, is there a particular protocol with your CT scan that you use in order to make it useful for your computer navigation? In terms of, I think the question is related more to slice thickness compared to regular CTs. Is it same as regular CT or different in thickness?
No, there is a protocol that has to be followed. And usually these are much thinner cuts, the 0.6 millimeter cuts, so it can be segmented at the level of detail necessary for this. And that's something that, although I don't understand the technology involved, it was something that was relatively easily worked out with our radiology staff and IT people.
Thank you very much, Dr. Kwon. There is a question from the audience for you, Dr. Kwon.
Okay, so the question was,
what are your current indications or algorithm for hemiarthroplasty?
I actually don't remember last time I put in a hemiarthroplasty. I think this would be perhaps in a revision situation where the glenoid just cannot tolerate or is not big enough with enough bone stock to tolerate a component. And then perhaps we put in a hemiarthroplasty, but I think for majority of the case, that's going to be pretty rare these days.
Dr. Virk,
yes.
Dr. Virk, I've had to do a few hemiarthroplasties for failed anatomics with inadequate bone stock, as Dr. Kwon points out. But in these situations, it's wound up to be stage one of a two-stage procedure, bone grafting the glenoid and then reimplanting a reverse at a later time.
Very good. Dr. Strauss, there's a question from the audience for you, and the question is, why do you think cartilage restoration procedures don't work as well in the shoulder compared to the knee?
I think that's an excellent question. While you'd think that being a non-weight-bearing joint, the glenohumeral compartment would be great for a cartilage restoration, I think it's different forces than we're seeing in the knee, especially within the tibiofemoral compartment. I think within the glenohumeral joint, you're seeing a lot more shear stresses than you're seeing in the knee. And also in these early cases of early arthritis, we all know there's a tendency for like a posterior subluxation or a posterior shift in the forces that contributes additional shear stress to whatever cartilage restoration or repair technique you're trying to apply. So I think the forces are different, which leads to some of these, some of these potentially worse outcomes than we're seeing with the similar procedures performed for relatively similar indications in the knee joint.
There's another question for you. What are your indications for arthroscopic capsular release for arthritis?
For arthritis. So that's also another good question. So it's definitely part of the discussion we have when we see these young active patients. And for me, I think it's primarily the really active patients. It tends to typically be like our weightlifting population who are more concerned about limited range of motion than actual arthritis-related pain. So the discussion is, by doing the capsular release, can we give them a little more rotational range of motion, which will allow them to maintain their activities despite the fact that they have some arthritis-related pain symptoms. So in that discussion, I think that there is data to support a benefit, albeit relatively short-lived, as we discussed. So it's definitely part of the algorithm when we see these patients, and it's primarily for those whose primary complaint is more limited motion than pain.
So any contraindications in your practice for arthroscopic capsular release?
Yes.
Or you would offer to any young patient?
No, that's a good question. I also think it depends a little bit on the imaging that we're seeing. I'll be much more apt to discuss a capsular release for a patient that has arthritis but has some joint space present on their plain films. I'm hesitant to discuss it or indicate it for patients whose joint space is severely narrowed, where it's basically bone on bone.
So there's a question for me. How do you decide intra-op or pre-op if you're going to use a short stem or a stemless implant? That's a great question. And I think, as I pointed out in my slides, I typically tend to use a stemless device in anatomic replacements in young males who have a good bone stock. And the way I try to figure out, I don't think it's an absolute science, but I use what is called a thumb test. I can't recollect who described it, but I did not figure this out. So once I make my anatomic head cut, I will use my thumb and gently push down the medullary canal to see if that tends to give in easily. I won't intentionally try to create a hole there, but I would try to see if I have a good feel for that bone underlying. And if I feel that bone stock seems to be good, then I would typically, if I plan for a stemless, I will proceed with that. But during the preparation of the stemless device, if I feel like the metaphyseal bone is crumbling and I won't have a good fit or purchase, which I can tell with the trial implant, I would abort the stemless and I would go to a short stem. And if during short stem I feel like I've already violated most of the metaphyseal bone, I would either select an impaction grafting, and if I don't like the stability, maybe a little bit of cementing. If not, then go to a standard stem. Dr. Kwon and Dr. Zuckerman, would you do anything different, or would you like to share any other technique that you use to decide when you are, playing between a stemless versus a short stem design?
So I only use stemless in younger patients with a good bone quality, and for me, I would not use it in somebody over the age of 50 as an arbitrary age. So, and I don't see very many of those patients, but those are the ones I would use. I think your idea about testing the quality of the bone by pressure is a good one. But I also think that I probably, compared to others, I underutilize stemless because I think the stemmed implants or short stem implants have worked very well.
Dr. Kwon, there's a question. Sorry, go ahead, Dr. Kwon. Sorry.
Yeah, so I guess that my thing is about the same as well. I obviously younger patients where I'm worried about revisions, I tend to utilize shorter or perhaps even short no stem implant, mainly because it is much easier to revise that prosthesis. But you cannot compromise fixation. So if there's not sufficient bone, either proximally, then you may have to go with a longer stem just to get better fixation on the humerus. I generally try to avoid using cement altogether. So if a short stem does not give me sufficient fixation, I'll just go to a longer stem to get fixation on the diaphysis.
So there's a question for all the arthroplasty surgeons on the panel. How does age factor in your practice regarding anatomic versus reverse shoulder replacement decision making? I'm going to ask Dr. Kwon to go first.
Yes, so that's the questionable or debatable indication for reverse that I brought up during my presentation. As the patients get older, their tissues tend to be a little more or a little less robust. So there are some patients, even though they do have intact rotator cuffs, the rotator cuffs are a lot thinner. So in my mind, an anatomic replacement is a place when basically all the soft tissues and the bone stock is in good or reasonable shape. So clearly it would be an arthritic shoulder, but the rotator cuff tissues have to be in perfect condition. In the older the patients get, less likely that's going to be the case. So for the majority of the patients that are older, it is a lot more likely that I will be inserting a reverse replacement.
Dr. Zuckerman, thoughts on age as a factor?
Right. So as anybody over the age of 80 gets a reverse, right? In my practice, I can't imagine doing an anatomic in anybody with who's over that age. I think between 75 and 80. The vast majority are going to get reverses, right? Because even though the rotator cuff may look structurally intact, it's hard to predict what their functional will be after you manipulate it at surgery. 70 to 75, I follow Dr. Kwon's guidelines. I look carefully at it. If the rotator cuff is intact and it's good, then I'm going to do an anatomic. And below the age of 70, in the absence of other mitigating factors, soft tissue or significant bone erosion, they're going to get an anatomic. Keep in mind, these are still somewhat guidelines, except for the over 80. As I said, I think I'm pretty rigid on that.
I think we have just 1 minute to go, and we have a last question, which is for Dr. Kwon. What are your thoughts on increasing number of reverses in past few years? Is it due to expansion of the indications, or is it because the reverse is more readily available and easy to use?
Probably all of the above, yeah. So clearly, as we just talked about, for an anatomic replacement to be used, the indications are for shoulders that has good rotator cuff and not significant bony defects. Majority of the cases don't fit that criteria. And if that's the case, then really the indication, then the reverse is going to be the major major option for those kind of patients. So just because of that reason, I think the number of patients that's going to require reverses are going to go up. We've been putting in anatomic replacements for a while now. Obviously, some of them are failing, and then certainly for revision cases, almost all those are being treated with reverse replacement. So just the indications are increasing for use of reverse, but the patients that need a reverse also is going up as well. And then finally, one of the biggest markets these days that I see among patients getting the reverses, or at least among some of these surgeons, is that surgeons who don't routinely do anatomic replacements do feel comfortable doing reverse replacements because they are either general surgeons or sports surgeons who are seeing patients, older patients with rotator cuff that is no longer repairable, and they feel like they could put in a couple of reverses a year and still have a reasonable outcome.
On behalf of everybody, I would like to thank all the attendees for being a part of this webinar, and I want to thank all the esteemed speakers who made this possible, in addition to Dr. Mike Lea and Dr. Mehul Shah, who also were a driving force for this webinar. I want to thank everybody. Everybody have a good night. Thank you very much.
Fantastic. Thank you so much to all of our speakers. And on behalf of NYU School of Medicine, I would like to thank you all for participating in today's event. Please feel free to download the course presentations in your handout section. You will now be directed to the CME login page. Please log in and take a moment to complete the appropriate course evaluation and attest to your credits to obtain your certificate. This concludes today's program. Thank you all, and have a great day.